we're going to cover off of your syllabus. We're going to talk about head injuries, mild to moderate. So when you're reading your book and it starts talking about all this craziness that you didn't hear me talk about in here, you can say, oh, that must be a level 4 thing, and just move right on by it, okay? So, because I can't teach you level 4 things because you don't know level 2 things yet, okay? And I tried on the slides to narrow down your page numbers, and I'll show you where I did that. We're going to talk about migraines. We're going to talk about brain tumors, both benign and malignant, seizures and epilepsy, and we're going to talk about back and spinal cord injuries. How you, as future nurses, are going to prevent them, because how many nurses do you know that, oh, my back? And that's the biggest thing. That's the biggest reason nurses call off work because their back's hurting. It's crazy. And we're going to talk about spinal cord injuries in here a little bit, because it's in level 3, but it is on your syllabus, so you need to know a few things. We're going to talk about all these neurotransmission disorders: Parkinson's disease, multiple sclerosis, Guillain-Barré, myasthenia gravis, amyotrophic lateral sclerosis, that's Lou Gehrig's disease, and Huntington's disease. And that should cover all of the objectives on your syllabus, because I've added the meds in where they fit. So instead of having random crap here and there, we're going to talk about this, then we're going to talk about the medicines, then we're going to talk about prevention. It follows in a logical order, okay? So this is what you need to be thinking about while I'm talking. The things that are in yellow. What are my clinical manifestations? What kind of signs and symptoms is this patient going to have with this disorder? Okay? We'll talk about all of those. Is there any way I could have prevented this problem from occurring in the first place? Okay? So basically that's just your injuries, not with actual physical things. What are my priority actions with this patient? And you see I have 2 categories down there. Biological needs. What am I talking about? Food, water, air. Who said air? They get an extra point. Air, that's a big one. Without air, you're dead. Circulation. What else?
I just asked if this is whose line. The points don't matter.
Yeah, they don't matter. I'm sorry. I wish they did. They don't. So your biological needs. So, we all know about Maslow's, and you know how you start down here with your physiological needs, and you have this, and you have love and belonging and self-actualization. I don't give a crap about those in here. We ain't getting there. We just got to take care of the basic stuff. I want to make sure that I'm meeting your biological needs, and I want to make sure that you are safe. If you want to actualize and improve your self-esteem, you need to do that later, but we got to get you through this crisis here to get there, okay? So for level 2, we're caring about our basic necessities and how we're going to prevent complications. What diagnostic tests do I need to do, or do I need to know about to diagnose my patient with this?
MRI.
Because what we're going to talk about each disorder and the test that goes with that, so you know which ones. What do I got to teach my patient? What do I need to know about that test to get my patient ready? So you need to be thinking about those things. Are there any medications that can help my patient? What do I need to know to give that medicine safely? And now I'm sending my patient home with a prescription. What do I need to teach that patient to make sure that they're taking that medication safely at home? So the things in yellow are the things you need to be thinking about with every disease process we talk about. Are there any surgical interventions? A few of the things we talk about have a surgical intervention that goes with them. If there are, what do I need to know? How am I going to take care of my patient? What do I need to teach them before I discharge them from the hospital? And then, are there any complications, and what can we do as nurses to prevent that client from going home and having complications from whatever this disease or illness is? So those are the things you need to be thinking about with every single topic. And I have them in a logical order on the slides where we're going to discuss them all, okay? Head injuries first. See right here, the chapter is like 45 pages long. You only need to read 10 pages. If you're going looking for something from level 2's lecture, it's going to be on those 10 pages on that slide. Okay, so don't read the whole chapter because you won't have a clue what they're talking about. Sometimes I don't even know what she's talking about. Did you ever notice it gets a little schizophrenic? I mean, she's all over the place. You think you're done reading about something, and then 2 pages later, you're reading about it again. You're like, so I limited your pages, okay, for level 2. This slide right here, we were talking this morning, there are just some things that you have to memorize. This is one of those things. This is one of those things. Because depending on where my injury occurs in the brain, I need to know what my deficit's going to be, okay? If I'm hit in the temporal lobe with a baseball bat, it's probably going to affect my hearing, okay? If I'm hit in the frontal lobe, it's probably going to affect my memory. If I'm hit back here, it's probably going to affect either my eyesight, if it's the occipital lobe, or if it's a cerebellum, it's probably going to affect my balance and my gait. You just have to memorize this slide. That's all there is to it. These 2 speech areas that I put at the bottom, Wernicke's speech area is in your temporal lobe, and Broca's area is in the frontal lobe. So if I have a frontal lobe injury, I'm going to have some expressive aphasia. I'm not going to be able to get out what I want to get out to you. Okay? I'm sorry.
Where was the Broca's at?
Broca's is in the frontal lobe, and Wernicke's is in the temporal lobe.
Thank you.
Now, what else is in your brain that you can't see in this picture that affects the body systems? How about your hypothalamus? It controls your body temperature, your sleep cycles, a bunch of hormones. So if I have a brain tumor and it's pressing on my hypothalamus, can it mess that stuff up? Mm-hmm. It can. We're going to talk all about that metabolism, but just be aware that it's there, okay? Also, your pituitary gland. If I have some brain tumor or a bleed or something in my head and it's pressing against my pituitary gland, it's going to affect the hormones that come from the pituitary gland, which affects every hormone in your whole body. So you can have problems with that. So just be aware that they're buried in the center of that. Can't help you here, you just got to memorize that. Okay? Sorry. With head injuries, your patient can have injuries from different forces. They can have it from the actual injury, like when I hit the brakes and my head goes forward on the steering wheel, I have an injury right here in the front. But when my head smacks back against the headrest, I also can have an injury in the back. And those are called coup and counter coup injuries. And you see how the brain is in there, but it goes forward and hits and has the bleed or the bruise at the front, then it goes back and you can have an injury in the back. So just because I hit the steering wheel and you might not think you have an injury in the back, you might, because the brain's floating around in cerebral spinal fluid. So those are the types and forces of injury. You can also have open injuries, which is a laceration, so a big cut on your head. You can have a fracture, which is a broken bone, and a penetrating injury. What kind of penetrating injuries do you think you see? Stabbings.
Gunshots.
Gunshot wounds, for the most part. Okay, so you can have all of those. Now, you're going to learn in level 4, if I have a gunshot wound, I'm now at a higher risk for meningitis and all kinds of other things down the road. So these are graduated. A big cut on your head, they bleed a lot, stitch them up, they heal. But if I get meningitis from a stabbing wound, I have a bigger problem. So can you see how I'm limiting you in here? We're talking about mild to moderate head injuries, nothing big. Closed injury is, you can't see anything on the outside. Everything has occurred in the cranial vault. What's the difference between a contusion and a concussion?
Concussion is lasting damage, possibly, but it has other like manifestations like puking and
Which one?
dizziness. Concussion. Contusion's just like a bruise.
Yeah, your contusion's a bruise. Just like you ran into something and you have a bruise on your leg or your arm, your brain has a bruise. But concussion, there's usually a loss of consciousness, there's some nausea, vomiting, it's a little bit more severe. So you can see when I have them on the slide, they're a little bit more gradually, each one gets worse. The bottom one, a diffuse axonal injury, is where you have the shaking. That's the injury that shaken babies get, because your brain's it's tearing the brain tissue, okay? So each one of those gets a little bit gradually worse. They classify them, mild, moderate, and severe. What tool do you think they use? Say it louder. The Glasgow-Coma scale. They grade them with your loss of consciousness and the Glasgow-Coma scale. We're only talking in here about mild to moderate head injuries. Anything is severe, just ignore it in the book. Here's how you're going to diagnose them. Their symptoms. They're going to come in, they're going to tell you, I got hit in the head with a ball bat, or, I fell and hit my head on the sidewalk, whatever. Here's your diagnostic test they're going to use, a CT scan or an MRI. See this chart right here? This tells you special important things you need to know about CT scans. But let's talk about a couple of them. What do I need to be aware of if my patient's going down for a CT scan?
When was the last time they ate?
Iodine allergy.
Okay,
Yeah.
iodine allergies in particular, because if they're getting any kind of dye, it's made with iodine. Now, if I'm allergic to shellfish or iodine, can I still get a CAT scan? Yes, they
Without
medicate
that.
you up with Benadryl and they still do it anyway. But at least they're aware of it and they're prepared if something should happen.
Yeah.
But IVP dye is iodine, so you have to assess for allergies. Somebody said about eating. For this particular one, a CAT scan of the head, it doesn't matter. If it is a CAT scan of your abdomen, you can't have anything to eat or drink, okay? Because they can't see through the food. I mean, your spaghetti's in the way, so you have to be empty. But your head, you can eat. What else you need to know? What do I need to tell my patient about it?
Metal, if they have any.
Okay, if it's an MRI, metal, shrapnel, no rings, no, if you were in
Piercings.
Afghanistan, you have shrapnel, piercings, artificial hips and knees, things like that.
Even in your
In
teeth.
fact, most hospitals have a checklist, and before they can go to MRI, the nurse goes through it with the patient, and then when they get to MRI, the radiology tech goes through it with the patient to make sure there's no metal interference. What else might I need to know?
Yeah.
Yes, I gotta tell my patient, when you go down there, you can't move. You have to be still, okay? Now, the difference between the CAT scan and the MRI, the CAT scan is the big open donut one. So they do have open MRIs now, but most hospitals still have the closed ones. What do I need to tell my patient?
It's gonna be a tight space.
You're gonna be in a tight space. You might be a little claustrophobic. Is it quiet or loud?
Loud
It's
and
loud. Yes, it's loud. So you need to warn them about that, because if you get in there and you're in the little tube and you start freaking out, they gotta either stop the test or, whatever. So you need to tell them that. One more thing you need to be aware of if your patient's getting IVP dye. If your patient's a diabetic, what medication do I need to be aware of? Metformin. Because metformin works in your kidneys. IVP dye has to be filtered through your kidneys, and the combination of metformin and IVP dye can cause acute renal failure. So you have to be very cautious about that. They stop the metformin. They like to do it 48 hours before. In an emergency, you can't, but 24 to 48 hours before, you can't combine metformin with the IVP dye.
You're still not to take it for another 48 hours.
And they don't take it for 48 hours afterwards. What do you think I need to talk to my patient about after the MRI? Do they need a ride when they go home?
Mm-hmm.
Can they drive themselves?
Yeah.
Yeah,
Yeah, unless
drive
they're
yourself.
sedated.
Right. Most people aren't sedated. What about lots of fluids? If the IVP dye works in your kidneys,
MRI you said, or CT?
either one. If I'm getting IVP dye and I don't have
You
a
need to drink lots of
contraindication
fluids
like congestive
afterwards.
heart failure, I need to increase my fluid intake to flush that out of my system. Okay? What lab do you think they need to check before they give you IVP dye? Creatinine and creatinine. Those are the kind of things that you need to be thinking about when you're taking test questions. You could safely send your patient down there for a CAT scan, okay? Because we know all these things about our patient. We've checked out everything we need to check out. My patient knows to be still. I know they're not allergic to anything. And so, you get the gist of what I'm saying? Okay. All the stuff is like that. Safety. Biggest thing, safety. Protecting your patient. Here's our signs and symptoms of a mild to moderate head injury. Kind of dazed, They might have a headache, maybe some temporary balance problems. You don't have to memorize this. Anybody in here ever been hit in the head? Yeah, you know what you feel like, you know? You're just kind of dazed for a little bit, and you might have some nausea, vomiting. The light might hurt your eyes for a little bit because you're super sensitive to the light. But I gave you a list of those so you can kind of look over those. Here's where the prevention of problems comes in. If I have a head injury and it turns out to be more than I really thought it was, and I didn't take care of my patient, I can develop all of these things, okay? Hypotension. What happens? You haven't had cardiac yet, because yay for you, that's tomorrow. Perfusion. If I have hypotension, what's happening to the perfusion in my brain?
It's going down.
It's going down. I'm not getting a constant blood supply. What two things can I store?
Oxygen.
So now I'm becoming hypoxic because I can't store oxygen in my brain. You're not perfusing me enough to give me oxygen. So now I have a secondary injury with hypoxia. I got hit in the head. I could have a hemorrhage. I could be bleeding. What's hydrocephalus?
Brain swelling.
Brain swelling.
Is it brain swelling?
Or
Right. I have an excess of cerebral spinal fluid for some reason. And we're going to look at a slide in a minute that tells you why that's a problem. I can have increased intracranial pressure. Okay, when you're studying and you're reading Iggy, if it says anything about increased intracranial pressure, and you're like, I don't even know what they're talking about, you need to stop reading there because you just don't need to know about that in here. That's definitely a level 4 thing, okay? There, I'll expect you to know that. Brain herniation, what is that about?
Brain bleed?
Mhm.
No.
No,
Oh, actually where it's
no,
poking
where
through.
it's kinda
It's a hernia where it's
busted
got
through
a,
the-
It's
Right.
coming through.
Foramen
Yeah.
in the bottom of your.
Right, it's either protruding through the foramen into that first cervical vertebrae. Is that good or bad?
Bad.
It's coming out your ear?
Bad.
Yeah. Brain herniation is terrible. That's one complication we definitely don't want to have. So, what assessments do you think you need to do when you're taking care of this person?
Look in their ear
Okay. Why?
to see if there's spinal fluid in it.
Yeah, to see if
That's
there's
true.
spinal fluid in there.
Oxygen, sac.
I need an oxygen sac. What if they're not breathing effectively? You know? Can I be breathing but not really moving air?
Mhm.
Yeah, so I need a sac. But I also need to listen to their lungs to make sure they're actually moving air. Because I can be breathing and not moving anything. What else do you need to assess?
Blood sugar? Is that what
Your
it's
barometer, vital signs.
You can check their blood sugar.
Mhm.
Because especially if it's a fall, did it happen because their blood sugar was low? You want to know, did they have any kind of seizure activity with the fall? Things like that. How did it happen? Where were they? Did they lose consciousness? Things like that that you want to assess on that patient. Do you think you want to do Glasgow Coma scale on this one? Yeah, I want to check them, especially if they're in the ER on my floor for a little while. I want to make sure. Do I want to teach mom? Does mom need to technically know the Glasgow Coma scale?
No.
No, but she knows what her kid was like when she took him home.
Mhm.
So 6 hours later, if the kid is not responsive, mom's got a problem.
Mhm.
And mom needs to be aware that he's not just sleeping, that's a problem.
Mhm.
Okay?
Yeah.
So without freaking mom out, of course. So, look, simplify. Okay? We're going to talk about ICP for 1 minute. I'm going to tell you why. Because on your syllabus for level 2, the drug mannitol is on there. Okay? I don't know why it's on there, but it's on there, so we're going to talk about it. I'm going to tell you what you need to know for level 2. This is your head. You got 3 things inside this hard box. You got a brain, you got your blood supply, you got cerebral spinal fluid. If anything is out of whack, let's just say I was in a car accident and now I have an area of my brain that has swelling or I have a bleed, something's got to give. So can you see how I can't change the shape of the box? So in this picture, I have decreased cerebral spinal fluid. You know, I have increased blood there. What if I had a brain tumor? Is that different or not different? It's not different.
No,
Something
it's not.
is inside of my skull taking up space where it doesn't belong. So you need to start thinking in terms of a space occupying lesion. It's occupying space where it doesn't belong. So it's affecting the other parts of my brain.
Yeah.
So you can see if I have a brain tumor, and it's right there at the top, and it's pushing right here in my frontal lobe. Can you see how I could have changes in personality?
Yes.
Changes in the way I problem solve? Because it's pushing in on my frontal lobe and taking up space, and so the frontal lobe can't function correctly. So get the term in your head, space occupying lesion, okay? Because it really doesn't matter what it is. Okay, you see this little person here? Does he look too sick for a level 2 student to take care of? Yeah. He sure
Just
the
a little
hell is. Stay out of his room. Okay? We're not taking care of him today. Okay? He needs respiratory support. You gotta learn all about that in level 4. Okay? We don't know anything about ventilators in level 2. Nothing. Okay? We don't touch them. We don't know about them. A ventriculostomy, that's a drain that goes straight into the cerebral spinal fluid and exits out the body into the bag. You think I want you touching that in level 2? No, I don't. So, no. Surgically, a craniotomy, that's where they take a piece of your skull and cut it out to make room for the brain tissue that's swollen. We really don't want to take care of those either in here because we don't know what we're doing. We can probably treat some underlying problems maybe, but we're going to learn more about those in level 3 and level 4, so we're going to leave them alone. We're going to talk about mannitol though, because it's on your syllabus. The reason we're going to talk about mannitol is because in this Cooper's lecture, y'all talked about hypertonic fluids. This is what I want you to know about mannitol in level 2. When you read your book and it's talking about filtered needles and filtered tubing and all this stuff, just ignore all that. Hypertonic medication. How does it work?
It increases the cell to swell, right?
Or
Or is it shrinking the other way? One of them don't go with brain injuries, I know that much.
Fluid back in the intracellular space.
How's it work?
It's from the intracellular space.
Okay, so I have my patient who has all this extra fluid in their brain.
They can't
Because
have
this
it.
really treats the brain ICP, okay? So what it does is it pulls that fluid back into the vascular system. Hopefully it's pumped through and excreted through my kidneys and I'm getting rid of it. So when I'm going back here and I'm assessing this little boy, I gave him some mannitol. And I'm walking past his room because I'm in a hurry. I got 3 other patients. What am I looking for real quick?
Urine output.
I'm looking for urine output. I'm looking at his Foley bag, and I'm saying, oh, okay, good. We got 100 cc's in there. Perfect.
Yeah.
And I come back a little bit. We got 500. Great. I'm assessing urine output. If I walk past his room and I don't see any urine in that bag, what better I be doing?
Checking him.
To do what? What am I checking?
Edema, you're looking for, yeah. It's going somewhere.
Nah, he's comatose. We doped him up. He's comatose. He's not going to be confused. We can't assess that on him.
No.
Because he's sedated. What am I assessing? Say it louder.
Lungs.
Say it louder. They didn't hear you in the back.
Oh, lung.
Breath sound.
I'm listening to his lungs. Because if the fluid's going through my kidneys and exiting in the urine, yay. But if it's not, that
Backing up.
fluid's still going somewhere. So if for
Filling
some
up that
reason
pump.
my kidneys aren't working correctly and I'm not getting rid of that urine, it's all backing up in my circulatory system and eventually I'm going to be short of breath, I'm going to have dyspnea, and I need to be assessing those lung sounds to call the doctor to get something else for him. So that's what I want you to know about mannitol. It's hypertonic. It pulls fluid from the cells into the vascular system. The expected result is increased urine output, but I'm assessing my lung sounds continuously because I want to make sure my patient's not getting fluid overloaded. Got it? So when you're reading in the book and you're all confused, call somebody who wrote that down and say, what should we say about that? Okay? Because that's all you need to know in here. Okay, any questions about head injuries? Can you see how simple that kind of was? You're in level 2. Kind of simple. I gave you the pages. Don't read like 45 pages. You don't have time to read 45 pages, do you? If you do, yay for you, but I mean, you don't. Because really, we're going to finish up lecture tomorrow and you're going to start cardiac, which is on the 3rd test. I mean, we're just rolling. So, now we're going to talk about migraines. Migraines are in your book. Look at that. 3 pages. 3 pages. You can find information in 3 pages. Google search your book. Yeah, you can Google search everything else. You surely can search read books. We're going to talk about migraines, okay? I know you're all good at Google searching. So this little slide right here tells you how a migraine progresses. And really what a migraine boils down to is you have a spasm in an artery, so you have constriction, and then you have dilation, and that's what causes the migraine pain, okay? So this slide just kind of breaks it down and tells you why they have increased sensitivity to pain. Has anybody in here ever had a migraine? Yeah. Are they fun?
No.
No, they are not fun. I've had one. I never want to have another one. It's terrible. So you don't have to memorize this. I just want you to kind of know the process. It's a constriction, and then a dilation, and then it releases a bunch of hormones and prostaglandins. It causes increased sensitivity to pain. That's why you have light sensitivity, sound sensitivity. Some people can't stand certain smells because it increases your sensitivity to those things. So that's just in there just so you can kind of understand how it happens, okay? Am I going to ask you a question like that?
No.
Of course I'm not. That's an AMP question. You already had an AMP. I'm going to ask you how we're going to take care of this patient. What am I going to do to prevent a migraine, to treat a migraine, to stop a migraine, those kind of things. So your book has some different kinds of migraines, and we are just going to talk in here generally about migraines. Okay, so don't get bogged down with, well, is it a cluster migraine, or is it this, or is it that? We're going to talk about headaches, big headaches. The terms to know, what's an aura?
Light.
Okay, like they can see the lights, a halo. What about smells? Some people have some people say, I can smell a certain smell before a headache comes on, before a migraine comes on.
Yeah.
So that's like a it's a predictor. So if I know that every time I have a migraine, before I have a migraine, I smell popcorn. I'm smelling the popcorn and there is no popcorn, I need to be like doing something to prevent this headache from starting. And that's what we really want to do. We want to catch the migraine in the aura stage so that we can stop it before it becomes a full-blown migraine. What is photophobia?
Not scared of light, but
Light sensitivity. They're very sensitive to light. What is phonophobia? Sound sensitivity. So those are just some terms you need to know, because if you see those on your test or on NCLEX and you're like, I'll be like, I'm sorry, that was on the slide. You know? So you might need to know what those words mean. So here's our signs and symptoms. They're disabling recurring headaches. They're often on one side. They're usually not bilateral. It's usually one side or the other. The pain gets worse with light or noise or smells. Talks about the aura there. Nausea and vomiting. Do you have nausea and vomiting with these? What's your priority when this patient comes to the ER? To piss them off by not taking care of them? No. If they're in the ER, they're there because they're having pain. Migraine pain is real, okay? I had a friend, we went to school together actually here, and we were both working at Biloxi Regional, and she had a migraine, went into the ER, and she was so bad, I mean, they couldn't turn the lights on, it was terrible. And she said, I couldn't even open my eyes. She goes, but the nurse who took care of me, I'll never forget her voice.
Yep.
Because she was so rude to her.
Oh.
And so we were in the elevator one day, and she's like, that's the nurse I had in the ER. She knew who
Yep.
it was.
Just by the
So
voice.
it's real. Whose perception of pain is real, yours or the patient's?
The
Patient's. Now, if they're texting on their phone while they're at 10 centimeters in labor, you know, and they say they're in pain, they're in pain, okay? So sometimes you have to look at them and say, well, everything's normal, but they say they're in pain. So it's not your perception, it's theirs. Sinus symptoms. Some people complain of the stuffy nose when they have the migraines. I know, I couldn't, no light, only the fan. I needed the room freezing cold, heat just bothered me. So, I mean, it's familial. Usually if you have a grandma and a mom and a sister who have migraine headaches, it's familial in families. It does affect women more often than men, but men can definitely have migraines too. And it usually, the onset is usually in their teen years or in the 25 to 40 range.
You know, I was gonna say my mom started when I was 16, and I can remember in her 40s. After then, it stopped. For whatever reason, she
Because
quit.
why would that be? Anybody
Hormone
else?
change.
Hormonal changes, because hormones affect that a lot and cause a lot of, that's on another slide up here, things that we can prevent. So history, how long have you had headaches? How long did it last? 24 hours, 48 hours, 18 hours? What were your symptoms? Those are the kind of things that you need to be asking your patient. Because if you don't have a clear picture of what's going on, how can you treat them? Physical assessment, neurological assessment. Do they do a psychological assessment? Sometimes they do. If you're in the ER repeatedly for migraine headaches and you're going to the neurologist for migraine headaches, there might be something more going on than just physical, so they'll do a psychological assessment. Imaging for patients over 50 years old that have new onset. Why do you think that is?
Because it's an increase for brain tumors.
Right, because if I have it after I'm 50 and I've never had a migraine before, is it really a new onset migraine, or is there something else going on that they're looking for to see, to rule out some other problem? So anybody over 50 years old that has a new onset of migraine, they're gonna do a CAT scan on. So this is what you gotta teach your patient. You gotta avoid the triggers. If you know that every time you drink chocolate milk, you're gonna get a migraine headache, then don't drink the chocolate milk. You know? I mean, it seems kind of simple, but it's hard to learn. It's a hard lesson to learn. So if you know that every time I eat lunch meat, because lunch meat has preservatives that can cause migraines, every time I eat that deli ham, I get a headache. Well, don't eat the deli ham. I mean, it seems logical, but yes.
Is one thing that we need to
It doesn't work that way, does it?
If
I know.
If you have a migraine on one side of your body, would it be affecting the other side?
It can.
Yeah.
We talk about that in level 3 with strokes. Yeah. So you got to teach them what the triggers are. We're going to talk about the triggers here in a minute, okay? You got to teach them the 3 R's. You got to recognize that the migraine's starting. That's the R up, okay? Is there something that you know that this is coming, that we can prevent it from happening in the first place? Then you got to respond to what's going on. And if you miss the opportunity there and you have a full-blown migraine, you got to relieve the pain. So pain management is the biggest issue with the patients admitted to the hospital or seen in the ER with migraines, managing their pain. Here's our triggers. See this right here? There's a chart in your book. I couldn't find a fancy picture that had all of them on, so go look at that chart because there's a couple other things on that chart. But alcohol is a migraine trigger for some people. Wine, things like that. Caffeine. Caffeine also is used to treat migraines. So some people who are caffeine addicts and they stop drinking caffeine all of a sudden develop migraine headaches because they have caffeine withdrawal. So caffeine can be a plus or a negative here. Skipped meals. What do you like when your blood sugar's low? You're cranky. You get a headache?
Oh, yeah.
I do. I get mean and I get a headache. Then when I eat, I'm all happy again. But your blood sugar has an effect on this and can trigger a migraine. Physical exertion. I go out and I felt good this morning and I went out and ran 15 miles, which is never going to happen, just telling you. It is, someone's chasing me.
Yeah.
But over physical exertion and the heat. So let's just say you were outside and you ran a mile. We ran a mile. We could all at least walk a mile, I hope. So we walked a mile real fast. We did a 7-minute mile across the bridge in Ocean Springs. That's how fast my husband walks. We don't walk together. He's very fast.
We don't walk together.
We don't walk together.
I'll see you when you get back.
What's your blood pressure like? What's your blood pressure like when you get to the end of the walk? It's up. Where do you hear your heart beat?
In your ears.
What's that doing to your blood pressure and all of this? So can you see how
Send it to
physical
your brain.
exertion, if you're doing something out of the ordinary, could trigger your headache? A bright light. When you go to the eye doctor, they dilate your pupils and they shine that light in your eyes. Can that give you a migraine? Sure
Yeah.
can. Yep, it can trigger a migraine. Excessive noise, smells, lack of sleep. Can that trigger a migraine? Yep. Stress, and I know it's so easy to leave. Well, you just need to learn your stress. What do you want me to do? Kill my family because I'll see you. I mean, come on. That's easier said than done. It really is. You can tell people all day long, just limit your stress and you'll do better. Okay. Weather
What
related.
world
Can
do
you
they
tell
live
when the
in?
humidity's different?
Oh,
Sometimes it
yeah.
brings on a headache. I think there's some other things in your book, like nuts can trigger headache in some people, but look at this chart, because there's some additional ones in your book that are listed that are triggers. How am I gonna, how's my patient gonna know to avoid this if I don't teach them? I'm gonna teach them. You just told me that every time you eat almonds, you get a migraine headache. So why are you still eating almonds? I mean, they may never have put the connection together, you know? So you have to teach them. Oh, you just told me that every single time. So you might want to avoid that in a nice way, of course. So abortive therapy, they had the aura, it's starting. I want to stop this headache before it starts. That's the goal. That's really the goal. And the drugs on your syllabus are triptans and argotamine preparations. Okay? You all know the first one up there, sumatriptan, that's Imitrex. So your patients are going to call it Imitrex. Your test, however, is going to call it sumatriptan. So that is one of the triptan drugs. It's the most common one used. And you can take that how? Does anybody know?
By shot and pill.
Yeah, you can take it as a pill, you can take it as a sub-Q shot. Most patients, when they get it, they say they have this immediate flushed feeling up through their head, because what's it doing? It's opening up all the blood vessels and letting the blood flow back up in there. So, look at the top. Okay, kindergarten students can get this. You can't take this medicine if you're pregnant. You can't take this medicine if you have coronary artery disease. Because if it dilates the blood vessels in your head, what's it doing to the blood vessels in your heart? It doesn't say, oh, well, I'm strictly for headaches. I'm not going to affect the heart. No, it affects all of them. So if you have symptomatic heart disease, you can't take it. Stroke patients shouldn't take this. And then that last one over there that you probably can't see from your seat, those are antidepressant drugs, SSRIs. You're not supposed to mix the triptans with the depression drugs, okay? But yes, and it does come in nasal spray too. I've only ever seen one patient with the nasal spray. But that's what you need to know about giving this drug safely. That and one more thing on the next slide. Oops. The argotamine preparations are a second line choice for drugs. Okay, DEH is the drug. You can give it IM, IV, nasal saline spray, or saline spray. Here's the thing. If I took my Imitrex or my sumatriptan, I can't take this for 24 hours. Okay? So I can take my Imitrex twice, 2 times in a row, but I can't take this for 24 hours if that didn't work. Most people will tell you that sumatriptan works. You know? So those are the drugs that you need to know about. You don't need to go into detail. There's like 2 sentences in your book about them. Which one should I avoid? Right here. Who should not take these? What do I need to know to take this one safely? If I took my sumatriptan, I can't take that for 24 hours. Don't get lost. Okay? Here's some other things that you do use to treat migraines though. Midrin is a combination drug. It's PO. And it has 3 drugs in it. They also use a drug with caffeine in it. It's Tylenol, a little bit of a narcotic and caffeine to knock out the headaches. So there are some things that your patient can go home on that will treat migraines if they need something.
We don't have to know that yours that one.
But that Midra is the most common one used to treat migraines. Yes.
What about if you are pregnant or something?
Under your doctor's care, you can take them, yes. But I would not take my Imitrex or the DHE without asking my doctor first. But yes, you can. Beta blockers. This is preventive. So I'm going to put somebody on a beta blocker to treat their migraine headaches. Is this a PRN medication?
No.
Nope, it's not PRN. It's a medicine I take every day to control my headaches. Is beta blocker going to know, oh, I'm taking this for headaches. It's not going to affect anything else. No. So what do I need to teach my patient? Throw on a beta blocker.
Take it every day.
Take it every day.
Watch your blood pressure.
Watch my blood pressure and my heart rate. Because what do beta blockers do to your heart rate? They drop it, so I want them to check their heart rate every day to make sure that they're above 60 beats per minute. Also, beta blockers and people with asthma just don't go together because beta blockers can cause bronchospasms and trigger an asthma attack. So if you are taking a beta blocker and you have asthma, you need to really discuss that with your doctor because it can trigger an asthma attack. Yeah.
Is that why one of the main side effects of lisinopril is coughing?
Now, lisinopril is an ACE inhibitor.
Okay.
Yeah, that's an ACE inhibitor. Calcium channel blockers, they use those for headaches sometimes, and anti-epileptic drugs, but we're going to talk about those with seizures, okay? Yeah, AJ?
What are like the pharmacokinetics behind beta blockers causing a bronchospasm?
I don't
What
know.
does it do exactly?
I don't know. You'll have to ask Ms. Cooper that because it's
Okay.
really, truly a cardiac medication, and asthma patients have to use it very cautiously. Okay, brain tumors. There's 5 pages in your book about brain tumors. Let me just clarify something about brain tumors. There are 959 names for different brain tumors because they're classified on where the cells originate, where the tumor's located in your head, all kinds of different classifications. I think there's like 4 of them. Do you think you need to know that? Nope, because I don't care what it is. It's taking up space where it doesn't belong. Okay? So I don't care. All I care about is what symptoms, I'm not the doctor, I'm not diagnosing it. What symptoms is my patient having because of this brain tumor? And what kind of treatments are available to my patient because of this brain tumor? So even though this is 5 pages right here, a lot of it is a bunch of gobbledygook about staging and location and all that. I don't care. It's a tumor taking up space where it doesn't belong. Okay? Y'all want a break? Okay, 10 minutes.
Man, that wasn't fast, however.